Hi, Tobias Kohler back again for Mayo Men's Health Moment, Rochester, Minnesota. Today we're going to talk about penile implant infections, updates in the medical literature, otherwise known as game changers. So we're very proud of our low infection rate here at the Mayo Clinic. The reason we have such great success with very few infections after our penile prostheses is we have a lot of experience and we know the literature very well. That is to say, we examine all the evidence out there and figure out what works and what does not. At the end of the day, infections should be the things that surgeons are most worried about for penile implants, because if you get an infection, typically you have to take the device out. This means another surgery with a lot of pain, cost, and the best chance for success in general for penile prostheses is the first try. So you really have to work hard to not get an infection the first time. And I think it's totally reasonable for patients considering the surgery to inquire what their surgeons are doing in terms of how they best and what their practices are to control infection, and to make sure that they're doing the right things. So we've done a lot of work in this area, and pictured on the screen is a paper that we recently published on myths and realities of implant infection. This paper basically looked at all the literature out there and graded the evidence as to how strongly you should follow advice doing these things on the list based on how strong the evidence is. Oxford Criteria Review means that when you look at the evidence, you grade it 1 through 5, 5 being essentially opinion of the doctors, and 1 being really, really good high-level evidence where you have many, many people coming to the same conclusion. So if you look at Table 1, you see a list of all the different things that we know can affect infection, or we think maybe affect infection. And you can see right away is that the level of evidence, with number 1 next to it, is pretty is limited to only a couple things. It involves what you wash the patient's skin with, whether or not you smoke. Clearly you should stop smoking before you get the surgery. How you prepare the patient, and so on and so forth. So all these different techniques can potentially minimize your risk of infection if you do them properly. But some things that I would have you pay attention to is that the technique at which is used, whether it's a penoscrotal or an infrapubic approach, does not matter. Age typically does not matter for infectious risk, so the same risk of infection if you're less than 50 or 80. In general, obesity has not shown to be a significant factor. So, the ones that don't affect infection are as important as the ones that do affect infection. And the ones that do affect infection, you want to make sure that your surgeons are doing the right things. So I'm not going to belabor these points, but again, there's many different variables that we look at. What I did want to go over in this talk over some of the newer thoughts and newer practices that your surgeon should be considering, because these are very, very kind of new studies. All right, so these 3 papers are all out of the same group, Dr. Manuro's group, out of Boston. He does a lot of great work on infection, deserves a lot of credit for really pushing the ball forward. A lot of his work has centered around basically getting a bunch of high-volume implanters together and figuring out why people are getting infections. And so these 3 studies here cover many different topics, but the take-home points are, number 1, it turns out that the antibiotics that we routinely use, or we're advised to use, don't always cover all the bugs that we need to cover for. This is specifically true for fungal infections, which occur about 10 to 15% of the time in implant infections, depending on which textbooks you read, and also bugs called anaerobes. So what the paper has done in this regard is make us give different antibiotics in addition to the standard ones if the patient has diabetes or if they're obese. Those 2 factors lead us to give more aggressive antibiotics. Another thing they've discovered is that time of year at which you get your surgery turns out that does have some effect on whether or not you get an infection. So that's pretty interesting. They found that if you had your surgery when it was more humid, you tend to get more fungal infections. So Interesting data, more work to be done here, but again, interesting work. And the take-home message is if you're diabetic or too heavy, we should give antifungals at the time of surgery. This is also true for any kind of revision surgery. So if you're getting implant fixed because a part broke, or if you need it moved around or something like that, you should give kind of more antibiotics than we typically do. Another paper, which is recent, talks about at the time of a revision surgery, what we typically do, we'll wash out the implant space before we put the new device in with different chemicals. Well, our group tried to use some of these washout chemicals for routine cases, and we quickly discovered that this was not a great idea. As a matter of fact, people used to use betadine and hydrogen peroxide. These are two kind of chemicals that kill bacteria on contact. And so it sounds like a good idea at the time to basically rinse your operative field with this stuff to kind of wash it out. But we found that it actually made things worse, because what we did is probably, we're guessing here, but we probably made the tissue weaker and more susceptible to infections, and thus it actually increased the infection rate. So our take-home message from our trials is that you should not use either of these irrigation fluids, betadine or hydrogen peroxide. We're trying to get this paper published currently. It's in the process. Another recent paper that I think is very, very important came out of the orthopedic literature, talks about operative speed and efficiency. We've known for a long time that experienced surgeons get less infections, they have less problems. It was unclear why, whether it's they know not to operate on some patients because they're too high risk, or why they do better. But it turns out that the faster you are, the less infections you get. This was an orthopedic study in which they took 17,000 patients over like a 12-year period. Overall, their infection rate was pretty low, 1% at 90 days and 1 year respectively. But when they looked at the guys who did get infections, it turns out that for every 20 minutes that they took longer in the operating room for these standardized procedures, the infection rate went up 35% at 90 days and about 25% at 1 year. They basically say that operative speed is an underappreciated risk factor in the operating room, and improvement in speed will decrease infections. And so I think, personally, this is something that I believe for many, many years. Now finally we have some data to support this thought. Remember, though, that surgery is not a race, and if you go too fast, you risk getting other complications. So you don't want to rush, but you do want to be experienced enough so you can move quickly to help minimize the chance of infection. I think a reasonable goal for an implant case should be an hour or less for a first-time implant. If it's a revision case or some other more complicated version, well, then that time is going to increase as being a reasonable one. The next study I'd like to talk about is postoperative antibiotic use. So there's been a lot of debate whether or not the pills that we give patients after the surgery make any difference. We know that the IV antibiotics that we give patients at the time of surgery are very, very important. But what about the pills that we give you to take for a few weeks after the procedure? So this study is out of JAMA, which is one of the top journals. Basically took 300,000 patients who underwent facial plastic surgery over many years. And it turns out that the men and women who got antibiotics and took them were 4- and 7-fold less likely to get infections. So that was a big difference. We've never had data like this before, and we try to weigh the risks and benefits of giving unnecessary antibiotics if they're not proven versus the risk of getting infection postoperatively. The thing that makes implants unique is that if you get an infection with an implant, you typically have to take the device out, and it's a big disaster. Whereas if you get, let's say, a wound infection after a hernia repair or like an appendix surgery, you can take a few days of antibiotics, and it's not going to affect the outcomes of your surgery. But when you put an artificial device in and you get an infection, often the bacteria will live on that device, and you won't be able to kill it with antibiotics, so you'll have to take out the whole kit and caboodle. So a really, really important study is that it turns out that post-operative oral antibiotics make a difference. And it took a very, very big study, 300,000 patients, to show it. But this is supporting kind of the practice that most high-value implanters have been using for many, many years. Interestingly, in this particular study, they also found that patients who are at highest risk, smokers, diabetics, immunocompromised, were less likely to have gotten the antibiotics in the first place, which, again, if you want to say, oh, I don't really believe this data, and you want to kind of not give antibiotics as a surgeon, I'd say in low-risk patients, maybe that's reasonable. But in guys and gals that are diabetic or immunocompromised, I think postoperative antibiotics after some kind of implant procedure makes a whole lot of sense. Well, I hope you found today's video informative. If you have any questions, as always, you can call the number on the screen or email us. Otherwise, stay well. Toby Kohler signing off. Mayo Men's Health Moment, Rochester, Minnesota.